Hi, everyone. I hope everyone can see me and hear me well. My name is Agustina Gancia. I'm the lead for capacity building at Health Translation SA. I'll be hosting today's webinar on health economics. And I'm so happy to see that so many people are trickling in. I'm seeing participants just popping in one by one. And it's great. We have a very interesting session today with Andrew and Martin, who will be telling us a little bit more about their experience. Before I start the webinar officially, I'd just like to acknowledge the Ghana people as the traditional custodians of the Adelaide region. We recognize the Ghana people's cultural, spiritual, physical, and emotional connection with their land. We honor and pay respects to Ghana elders, both past and present, and all generations of Ghana people now and into the future. I also would like to acknowledge the other lands from which you may be joining us. I know there's a few interstate people listening in today. So if you want to maybe pop it in the chat, say where you're joining from, that'd be really lovely. So some of you might be familiar with our Spotlight Series initiative. Some of you might not. What is a Spotlight Series? Essentially, it's a quarterly initiative that HTSA has started in 2021 now, so almost 2 years ago. And essentially, it's us shedding the spotlight on a specific topic around research translation. And this month, our focus is on health economics. And so each week we have a weekly webinar around a certain topic on health economics. We also share through our social media. So if you follow HTSA on Twitter or LinkedIn, you'll see that every day we'll be sharing either publications, training opportunities, website links to that are all related to health economics. Our previous Spotlight series were on a variety of topics. So the last one in October was on consumer engagement. We've had a whole month focusing on the MRFF. We've had a Spotlight series on research impact and one on implementation science. So we've now built up quite a little library of Spotlight series, different topics, and these are all available on the Health Translation SA website for you to listen to the past webinars and for you to access all of the resources that we've shared in the past. So who are we? Who's a Health Translation SA? HTSA, our purpose is to accelerate the translation of research findings into healthcare practice and policy. And we want to increase the whole of system research translation capacity to improve the health of all South Australians. So what that means is that we work with all of those partners that you see at the bottom of the slides. We've got 11 partner organizations, and we bring people together. We ensure that research that's being made in South Australia actually gets translated or applied into practice and policy. The way that we work, the way that we do our work is that we are an independent catalyst and a broker. So we mobilize collaborations between researchers, health services, education, the community, and different key stakeholders so that we can all together address major health system challenges. And our main message that we drill to people over and over is that research translation is a mindset. It's really something that you must think about from the start of a research project, not only after you've finished a project and then, what do I do now? Do I implement it? No, that's not how it works. It's you have to start thinking about what's the ultimate problem you're trying to address, who's the next user and the end user of your research, and are these people actually involved in your project? Do they have a say? So all of our work and our initiatives come back to this concept that research translation must be thought of from the beginning of a research project. Today, we're going to be hearing from two researchers, Martin Henscher, who comes to us from the University of Tasmania, and Andrew Partington, who comes to us from Flinders here in South Australia. And they'll be telling us a little bit about their experience, how their experience in the public sector has shaped their academic directions in research around, health economics, obviously the topic. So before we dive into Martin's presentation, I'd just like to introduce him formally. He is the Henry Baldwin Professorial Research Fellow in Health System Sustainability at the Menzies Institute for Medical Research, and that's at the University of Tasmania. His work explores how healthcare systems can meet the environmental, economic, and social challenges of the years ahead. And he has a wealth of experience in health economics and has gained experience in many different countries like the UK, Australia, and continents like Africa, Europe, and Central Asia. He's held roles in different departments of health, including in South Africa, the Department of Health in England, and was a senior executive at the Tasmanian Department of Health as well. So he's currently a member of the South Australian Health Performance Council, and he's also, fun fact, a volunteer search and rescue specialist with the Tasmanian State Emergency Service. So he's got quite an impressive bio. I'll just stop sharing my screen now, and I'll invite Martin to share his screen and talk to us now for the next 20 or so minutes. So, welcome, Martin. Great to have you with us.
Thank you, Agustina. Let me get the right ones. Here we go. So, how's that looking? Can people see that all right?
Yes.
Very good. Okay, I'm just trying to sort myself out here. Here we go. So are you on the right view there, or do we need to flip it around? Yeah, here we go. Good. How's that? Is that right?
Excellent. Yeah.
Perfect. Okay, so I'm going to say a couple of words first just about the Health Performance Council, and then move on really to talk more about kind of health economics and my career and what I'm doing now. But just bear with me talking to John. We thought it would be useful just to say a couple of words for those who might not be familiar with the South Australian Health Performance Council. So the Health Performance Council is an independent statutory body. It provides expert advice to the South Australian Minister for Health and Wellbeing. And it's got a focus both on population health outcomes, on the health system, but also actually about community engagement on all aspects of health. It's got 8 members, of which I'm one, and it's chaired by Stephen Duckett, who I'm sure everybody has come across. So it's unusual in that there's actually 2 health economists on the Health Performance Council, which is an above average representation for these kinds of bodies. And we get support from an excellent team in the Commission on Excellence and Innovation in Health. The kind of centerpiece of what we do as a council is a 4-yearly report, which is a big performance report on the health of South Australians and the performance of the South Australian health system. And when we say the South Australian health system, we don't just mean the state health system. We have a remit actually for all of South Australian health. So primary care, hospital sector, private sector, it's all potentially within the remit. That report's tabled in Parliament, and the government actually then formally tables a response to it. And we've quite recently tabled our latest report in December with a little bit of an update actually in February, which was from 2018 to 2022. And then our job is to then actually kind of drill down and identify some actionable elements from the report and advise the minister on some priorities for improvement coming out of that. And this is a very ugly looking web address, but hopefully if the slides we can sort out to share the slides. It's worth a read, I think, of the latest report. I'm sure if you haven't looked at it, I think you hopefully would find some good insights in there about what's been happening in the South Australian health system and some interesting trends. We identified a number of these areas that we worked across, but we're coming out of that, we've chosen 2 priorities for the council to work on to develop further. One of which is reducing hospital inpatient stay, and actually looking in some specific areas, but looking at really where problems with long lengths of stay look to us like they're backing up through the system and impeding flow, emergency care, ramping, all of those kinds of things. But then the other big one that we identified was the real need to improve workplace culture across the South Australian health system. And we're going to be spending some time thinking about how the whole system can really improve culture, satisfaction, employee engagement, etc. So going forward, we're going to look at that length of stay issue and really review how SA Health deals with workplace culture, workplace satisfaction, etc. Then we've also been directed by the Minister to do an inquiry into palliative care across South Australia. And the 4th area that we've chosen to look at is to think about how effective is the South Australian health system's mechanisms for community engagement. So we're going to be putting together a piece of work on that. So that's just to give you a quick flavour of what the Health Performance Council does. And now, if I can organise myself, I will switch across to my other slides, and we'll get back to the world of health economics. How's that? Does that look right? Good. Okay. So ignore that title, but I would just like to also, sorry, I should have done this before, but with the different slide sets, just acknowledge the Palawa people as the traditional owners of Lutruwita, Tasmania, where I am, and acknowledge that their sovereignty was never ceded, and pay my respects to their elders, past, present, and future. So, my life in health economics. Well, nobody ever said this, did they? It's not something you think about in primary school, let's be a health economist, and it certainly wasn't for me. I've been very privileged, though, to have a fantastic career, really fascinating and exciting, satisfying career over many decades in health economics. Although I started up, which was what I did always say to my mum I wanted to do. I started with a stint in the army, in the British Army, which has proved to be a fantastic resource actually throughout my career, and many things I learned very young as a young and not necessarily brilliant infantry officer have actually served me very well throughout my career. Then after university, I joined the NHS, who was really the first people foolish enough to give me a proper job, and found I'd honestly never even thought about healthcare before in my life, but found it was very interesting, and in particular discovered a thing called health economics. Having done economics as part of my first degree, was oblivious to health economics at that stage, but discovered there's this thing, it's called health economics. Did a master's at the London School of Hygiene and Tropical Medicine, specializing mainly in health economics and financing, and then was very fortunate to get a job with an organization which sadly doesn't exist anymore, but called the London Health Economics Consortium, modeled after the York Health Economics Consortium, but it was owned by the School of Hygiene and Tropical Medicine. And we did, well, they wanted it to be a profit-making consultancy that would cross-subsidize the School of Hygiene and Tropical Medicine. I think we did turn a profit, but we didn't do a lot of cross-subsidizing. But what we did was some incredibly interesting work, starting off in the NHS, doing really, applying health economics principles to things like hospital at home, alternatives to hospital care, step-down care, things that we're still talking about how we need to do now, 30 years on. We were applying health economics analysis to that then at that stage. But what it did for me was, in particular, also largely by accident, you will have noticed a theme appearing now in my career, but largely by accident, we got ended up doing a lot of work in the former Soviet Union. This is in the years after the end of the Soviet Union. We got pulled into particularly Central Asia, Kazakhstan, Turkmenistan, Kyrgyzstan, to try and rebuild their health systems. And the rebuilding of their health systems was basically because the first wave of reform, which had been led by the IMF and the World Bank in those countries, privatized all of the former state industries. What unfortunately the privatizers hadn't noticed was they'd assumed that healthcare in the Soviet Union was run by the state. Well, in fact, most healthcare and actually a lot of the education system actually was nominally run and belonged to state enterprises, not actually local governments. So when they privatized all the tractor factories and the collective farms, all of these enterprises were left running hospitals and clinics, which they could no longer afford. And the healthcare system started to basically shut down. So we went in as a kind of second wave of reform to try to rescue the social protection system in the Central Asian republics and get it back on track. And that was incredible. So I would go to the American Express office in Mayfair in London, where I'd withdraw 50,000 US dollars, which I would secrete in my underwear, fly into Kazakhstan, and then that would be the operating kitty that we would use for the expenses on the ground of what we were doing. And had a just fantastic time working there, very exciting, very challenging environment, but really trying to restabilize the health system in the wake of this incredible social dislocation that had happened in the Soviet Union. That then also got us a ticket into working in sub-Saharan Africa, which was the closest thing to a kind of health economics ambition I had at that stage. We did some fantastic work, particularly for the European Commission on blood transfusion financing. One of my proudest achievements still is that we were able to persuade the European Commission to not introduce user fees for blood products in programs that they were financing in African countries. We were able to show that this would be very regressive and would really kind of critically impact on vulnerable populations. And that was a great kind of win, if you like, as a translation early on, that we were able to persuade them to change track and not introduce user fees for really the most vulnerable people who are typically who's actually receiving blood transfusions in a developing country setting. So from there, I then had an incredible privilege to go to South Africa. So I was employed by the European Commission, but I was embedded in the South African National Department of Health in Pretoria. They had a directorate called Health Financing and Economics, which was a little team, but a really good team of South African health economists. And we did loads of just amazing work there. There was started off the kind of the initial project was a big reform of the private health insurance system in South Africa, and that was really where I kind of learned a great deal about health insurance and private health insurance, and the golden rule of private health insurance, that nobody ever made money by paying out claims, and that's good in all systems and all settings everywhere. So you have to remember that that rule. But then we moved to South Africa in 1998. That was the time really when HIV/AIDS was really becoming a critical problem in South Africa. And also shortly thereafter, where the older amongst you will remember that there was a real problem of HIV denialism within certain sections of the South African government, in particular, a real refusal to make available different kinds of antiretroviral treatment, initially prophylactic antiretroviral therapy for newborns, but then antiretroviral therapy for people with AIDS. So that was there in a really exciting time for that. And over a period of years, led different approaches to really using health economics modeling to, first of all, argue for bigger budgets just for general HIV prevention and AIDS care, but then down to the pointy end really of using cost effectiveness analysis models to argue for the introduction of antiretroviral therapy as the prices of those drugs started to come down internationally. So that was really incredibly exciting, intellectually demanding, politically pretty brutal. It was often quite hard work. One Saturday, I got called into the office, and the president had sent a fax to the director of the HIV program with like 50 questions that he wanted answered by Monday morning on what was going on with antiretrovirals. So we had to get to work on that. It was an extraordinary time, but it was quite striking, though, the impact that we were able to make with, let's say, very general health economics modeling on having a real impact. We were not using, even then, this is 20 years ago, but even then we were absolutely not using state-of-the-art, super-duper, very best cost effectiveness models that people use for health technology assessment. We were using much cruder epidemiological models with costs and effectiveness stuck in, and that was incredibly powerful for influencing policy. And that was a big lesson I took away, is simple is usually more effective than complex in these big policy debates. The other thing I did, which was just also really exciting, was over a period of years, we designed a new funding model, I should say, for the South African tertiary public hospital system. And that was a huge effort, which actually involved a bit of health economics, but was much more really a big engagement and planning exercise with specialists across the system, involved getting to know lots of the specialists, working closely with them, trying to build their trust in planning processes to kind of redesign the South African tertiary hospital system. So that was really good fun. And again, often, well, again, a key lesson from that is health economics is very powerful, but is never sufficient in these policy processes. You always need other disciplines, other techniques, other approaches when you're working in the policy space. Then 2004, we moved back to London with plus 2 children that we hadn't had when we went to South Africa initially. And I got a job in the Department of Health England in an organization called the Government Economics Service. So the civil service in the UK has this specific economics stream called the Government Economics Service, which has people who work in individual departments, but it allows the kind of central professional standards for economists across the central government. That was very fascinating because very few GES economists are health economists, even in the Department of Health. I was one of the few people in the Department of Health who was really a health economist first. That was pretty interesting. But there we did, again, really fascinating stuff. I had really, if I'm honest, I was working more as a specialist manager than as a jobbing health economist. And as many people find over the course of your career, as you get more senior, obviously you spend more time leading and managing than as doing the technical work. And that's just the nature of life. But my teams did fantastic stuff. So we worked on a huge program called the Vascular Checks program, which introduced a series of health checks for vascular health, as you get coronary heart disease, stroke, etc. Using really excellent cost effectiveness analysis to identify the kind of optimal shape for that program. We looked at the economics of end-of-life care, of the economics for a big cancer care strategy. And after the GFC, we got plunged straight into where are we going to find the savings in a national health service that had been having loads and loads more money pumped into it for the previous 10 years under the Labour government. Suddenly the brakes were on. We could all see that austerity was coming. So how could we try to save large amounts of money out of the health system whilst maintaining sustainable and high value care? So that was a really good experience, and working with incredibly high caliber people. That was, I think, the thing I took away from the civil service was the caliber of the people I worked with, was of economists and otherwise, was extraordinary. And then by a complex process, which I won't bore you with here, I found myself in Tasmania in 2011 with my family in the Tasmanian Department of Health, working really mainly on strategic planning, in health information, kind of a bit of health economics, but really mainly kind of, leading health strategy for the Department of Health. And as you do late in life, my particular midlife crisis was to start a PhD at the age of 49, which I'm not entirely sure I would recommend, but I did anyway, got my PhD, which I'll talk a bit about in a second. And then in 2019, we had a family move to Melbourne. My wife needed to study and upskill to do something that she couldn't do in Tassie. And that was great. That allowed me to get a job at Deakin University, jump tracks to academia. Haven't looked back. We're back now in Tassie because my wife has the job that training enabled her to get, and I'm very lucky to be back at the Menzies Institute here. Now, why did I change tracks? Why did I do my PhD? Well, while all this is going on outside the world of health economics, you will have noticed the world around us is changing. And in 2012, I found myself on what was described as the primary search of Dun Alley. Some of you remember it was a town on the Tasman Peninsula that was destroyed in a bushfire in 2012. Our job was, to put it bluntly, was to find the dead people. Miraculously, there were none, but that got me thinking. And of course, in the years since, we see more and more climate impact, and I've become more and more aware of the wider interplay between health, healthcare, and the environment. And that's what my PhD was about, called Health System Sustainability, New Perspectives from Macroeconomics and Ecological Economics. And I guess my mission here at UTAS is to look at health system sustainability research in a way that brings through the traditional health economics and finance focusing on sustainability, but adds in the ecological dimension, and in particular brings insights from ecological economics, a different kind of heterodox branch of economics. I've got way too many slides, which I'm not going to show you all, but I just want to show you a couple. Many of you will have come across the concept of planetary boundaries. It's very simple. Climate change is not the only ecological crisis we face. We actually appear to have overshot a number of critical environmental boundaries with very unknown and unpredictable, but probably not good implications for humanity and human health. And in this country, our environmental footprint is massive. So this just shows you Australia on the left versus Sri Lanka on the right. And we are in the red in all but one of these planetary boundaries, whereas Sri Lanka is well within its ecological capabilities, but inside what's the inner ring, this is Cape Raworth Donut, is not able, though, to actually provision its people with all the social necessities that they need. And that's at the heart of so much of this stuff. And ecological economics is a heterodox economics discipline, which is not only interested in efficient allocation, which when it comes down to it, that's what neoclassical economics and health economics is about. Ecological economics is concerned with the sustainable scale of the economy, actually how big is the economy and how big should the economy be, the fair distribution of resources, and the efficient allocation of society's resources. And fundamentally, a lot of the work I've been doing is about where are we with economic growth, the future of economic growth, and what that means for health and healthcare. And actually, we're close to the end of the era of economic growth. Like it or not, economic growth in the high-income world is getting slower and slower every decade. We're grinding down slower and slower towards zero. And there are very good reasons why that actually might not be a bad thing, why we might need to be in a post-growth economic model. And my work's really about what does that mean? What does that mean for health economics and health care? healthcare is intimately linked to growth, but more than that, healthcare has consistently grown its share of GDP for decades. So if something happens to growth, something's going to happen to healthcare. And how do we retool our healthcare systems for a future of lower growth? And what does that mean? And for me, really most critically, a lot of that is about how can we reduce unnecessary care? How can we minimize the demand for healthcare by actually preventing people getting sick, but preventing in particular the things in the economy that make people sick? All the commercial determinants of health, all the overconsumption which happens in our society, which drives ill health. How can we stop people needing healthcare? And once they get in the healthcare system, how can we make sure that they only receive necessary, beneficial, and high quality care? And in doing that, how can we also reduce the environmental impacts of the healthcare system itself? So healthcare, 10% of the economy in Australia, probably 5 to 7% of greenhouse gas emissions, national greenhouse gas emissions, come from the healthcare sector, but also a whole range of other nasties coming out of the healthcare system, including coming out of you if you are taking any prescription medicines. Between 30 and 80% of the active ingredients of the drugs you're taking come straight out of you when you go to the toilet and out into the environment. What do we do with that? All points in between. I don't think I need to labor how much climate change in particular is going to impact on health, but here's really where I'm getting to, which is for the healthcare system. As economists, we like to think about the demand side and the supply side, and the same is true for the environmental impacts of healthcare as it is for any other consideration of demand and supply and health. And on the top stack, so we need to do everything we can to act on the social and commercial determinants of health to prevent, preempt ill health, not even prevent perhaps, but preempt these societal forces of our economic system that drive people to illness. Then we need to do very effective primary prevention. If people get sick, we need to do effective chronic disease management, which we don't currently, because that we can hold so many people in a better state of health, even if they have a chronic disease, by better management. We've got to minimize low quality care, minimize overuse, overdiagnosis. And by doing all of that, we can minimize avoidable demand for healthcare, so that in the ideal is that only people who really, really, really unavoidably need healthcare go into the system, whilst on the supply side, we can do a whole load of things to minimize emissions, in this case for climate change, in the production of healthcare, from our power sources, from our plant and buildings, and most importantly, from the supply chain that we rely on all the way through. And this really guides most of what I do. I know in the trailers for this, you looked at some long COVID work. I'm not really going to say much about long COVID, but long COVID is a piece of completely new demand for healthcare, to some degree preventable, and added pressure on our health system. So when I look at it in this kind of framing, I go, that's bad. We need to manage that as effectively as we possibly can to keep it within this overall sustainability framework. And really, so that leads me to work on the health economic side, working on how can we incorporate climate and environment into health technology assessment, which is a growing area of interest internationally. But really, how though can we measure joint actions, the co-benefits of joint actions, which both improve health and reduce environmental impacts in healthcare? How can we use health economics principles, like all the work we did years ago on allocative efficiency and sectoral allocative efficiency? How can we apply that to things like carbon budgets, which will be coming down the track in the future? How can we adapt to the impacts that climate change is itself going to have on society and the healthcare system. And as I talked about, how can we adapt healthcare to a post-growth world in which we seem to be emerging. And I think I will leave it there so I don't run too horrifically over my time. Hang on, I've lost my stop share there, and I will stop and yield the floor at that point.
Wow, that was fascinating, Martin. Thank you so much for that thorough, I guess, journey through your background. It was so impressive to see how each experience kind of intertwined with each other, and one thing led to another. I have a few key messages here that I've taken. You know, that simple is more effective than complex when it comes to, you know, policy, speaking with policymakers. That whole last bit around, you know, environmental economics and the health economics, how they intersect. That's fascinating. I had never actually come across that, so it's a new area for me to learn about. I guess in the interest of time, I'm going to pass the mic over to Andrew now. I'll introduce you first, Andrew, before I let you share your screen. And then if we have time at the end, I'll have the audience ask some questions if anyone is interested to ask Martin and Andrew some questions.
I should say, Christina, I'm going to introduce myself a little bit in my presentation.
Okay, yeah, well, then we can go straight to you then.
Let's do it.
Straight to you if you want. So I'll stop sharing and you can share.
Partly as well because I think very nicely you've given me a bit of a promotion there. I'm just a research fellow, not a senior research fellow. For those colleagues who may be watching and being like, "Oh, has he been promoted lately?" No. So yeah, super interesting from Martin, and yeah, love hearing about that. I'm going to talk a little bit now about going from the macro down to more of an applied micro kind of perspective. Because that's more my experience. So similar to Martin, I've come through. I've spent some time in the NHS and also in state government, and I also didn't imagine myself being a health economist when I was young. I actually started out thinking I'd be a musician. Believe it or not, I went to a music school, studied a music degree, was teaching in high schools music stuff, and I loved that, but I wanted more mental stimulation. So now I'm a member of Flinders University, the research team there, and I'm based physically in Sydney at the Australian Institute for Health Innovation, where we all work together in this big national partnership centre looking at health system sustainability. My takeaway from all my professional experience leading into academia is that Australia is a crazy place when you work in other health systems. So I did a lot of commissioning, a lot of purchasing, a lot of service design, model of care design, as part of a consultancy within the NHS. Super interesting, much more simpler than the complex web of roles and responsibilities that we have in Australia across hospitals, primary care, other sectors. And there are lots of pressures that apply themselves onto the health system in Australia. And while I would love to see us sort of focusing down here on sort of internal emergence of quality improvement and development of the health system, from the bottom up, and really, let's be frank, lots of what dictates the priorities and the things that we work on in health systems is the media cycle. So capacity and flow is something that's in the headlines. It then becomes for good reason, but there are lots of pressures for change, and more we're trying to work in this space, but are aware that we can't decouple ourselves in an Australian policy context from some of the media cycle. But I want to throw this out there and just be a little bit controversial and say that we choose the level at which we sustain our health system. And of course, health budgets are large and they're getting larger. Martin talked about degrowth. I like the Kate Raworth stuff. I think it's very interesting. It's my partner's area of expertise, not so much mine. And so, of course, we want to think about how our health spending imposes costs on the other things that we would like to spend money on. Be it public finance or private finance, out-of-pocket payments, of course. But maybe in Australia, our levels of spending, particularly public spending, are particularly high. So I'm just throwing that out there. And I note that I am from a centre of system sustainability, But it's something that I keep I want to just raise, that it's not just me, but there is a lot of folks who talk about there being a bit of a sustainability panic. Okay, there's a myth that's perpetuated in Australian politics, particularly going back to sort of 2014 and some of the budgets around that period, around, the health system has to be sustainable. There's some good slides here, some good readings that I'd point you towards to help challenge perhaps your thoughts about that. Because at the end of the day, a fact is that Australia spends, our public spending is a lot lower as a proportion of our GDP than most other OECD countries. Okay, and so some of the thoughts by other health economists much greater than I, Jane Hall, Jeff Richardson at Monash, Jane Hall at UTS, say that, let's not just be concerned about costs, but we need to be thinking about, what are the benefits that come from a system that we're spending money on. And I note that Jeff Richardson and others pull us back to this idea of public finance, and it's a structural finance problem that we've got when it comes to health spending. We've done lots of reviews on how we may want to spend money better in the economy. So I've put down here, I've got Henry tax reviews and things, but also noting that a lot of that is just been kicked down the road. The burning platform has been lost. So just to throw that out there, that sometimes we talk about the health system has to be sustainable. Well, yes, but maybe there's something more to it. And I do know that there, of course, COVID has blown out health spending in different ways, but interestingly, it has created lots of new provider-partner relationships. And there is something really big with the with the NDIS. We don't know very much about the costs and the outcomes, and so we can't yet talk about value. So there's some things in there that we want to talk about with sustainability, but maybe Australia levels aren't actually particularly high. I wanted to throw this in there because the environmental sustainability is something that's super important, not something I know much about. So that's why I'm learning from Martin on this. But just to flag that the partnership centre that I'm involved in, and John Kahn and others are involved in nationally, is a member of the Climate and Health Alliance. And that is an area that they've gone to. So yes, we talk about economic sustainability, financial sustainability of health systems, but also more and more people are thinking about what are these environmental and macro impacts, noting that the healthcare system has a huge environmental footprint, as Martin highlighted. So this is more my starting point, where really it's all about unwarranted variations in practices, and important unwarranted variations in practices, trying to identify how we spend money and what kind of outcomes we achieve on a smaller micro level. So talking about particular patient groups, be they with chest pain or experiencing symptoms of stroke, how can we help different hospitals, different groups to look at what they're doing, what they're spending money on, what outcomes they're achieving, and how can they learn from each other on a micro scale. And out of that as well, we then start to think about, well, so how do we think about which models of care we should prioritize, and how much we should be paying for those? Because we've got lots of good tools in our shed in health technology assessment that's used for medical devices and pharmaceuticals. It's not, though, applied when it comes to health services. So we, the team at Flinders, and that are engaged in what we've talked about as being a search for efficiency. So looking at health services and thinking, how do we make that better? How do we improve the costs? How do we improve the outcomes? And we do a lot of this kind of brown paper mapping stuff. But it really is a holy grail in HTA, is to think about how do we apply some of our methods to the organisation and delivery of care, which itself, I know lots of people say, is a health technology itself. So that's our mission. That's what we're on about. Trying to find, that's what I'm on about. I don't want to speak for my colleagues, but it's part of the mission is trying to find acceptable and accessible ways for people across the health service, lots of clinicians, lots of health service managers, health executives, policy guys, to think about, to engage with economic evidence and think about the value of their services. And we do it in a way that's sort of explicit and transparent, contestable, updatable, all of that. I mentioned services before, so not so interested in clinical interventions. I am more interested in upstream sort of the conglomeration of multiple different types of small clinical interventions, but we probably draw the line at some of the public health policy stuff. And it involves this nexus, this collaboration of built environment, some of the equipment, the workforce. Workforce is a massive part of being a service rather than a product. And how that's all stitched together, the sequence and the timing of care that's provided. That's the kind of thing that we're looking at. I know that we know a bit. We have some insights into how Australian health system managers decide. And we're trying to think about how do we put evidence, economic evidence into that sort of space. We know how they decide, and that it's a very sort of fuzzy kind of process, and that the system is always adapting. It's always in a bit of a state of flux. So we're aware of that. We have to try and work with that. And we know how they want information then. Yesterday, can you give that to me yesterday? It needs to be easy to interpret. Martin made the point that, yeah, simple trumps complicated. And we need to be trying to name our biases, name our assumptions, because there's lots of assumptions that goes into economic evaluation that people need help getting their heads around, making sure that they're able to interpret what they're looking at. And so, part of then the theoretical aspect that underpins all of the stuff that I'm doing is thinking about how do we move economic evidence into a learning system type environment. So given that, we know how managers decide, and the nature of the system being complex, being political, being, it's dynamic, it's always changing, how do we try and build in some feedback loops so that the economic evidence can help nudge the system along in ways that improves costs, improves outcomes. We have some theoretical stuff around how we think about that. How do we think about complexity? What are the kind of levers that we've got around helping to understand probabilities and possibilities? I won't get into that too much, to say that we've got some main areas of application. Big ones are around structuring decision problems. So properly understand, what are we actually talking about? What is it relative to? So if we're going to do a new health service, what's it replacing? And then we do a lot of work on parameterizing, putting numbers to these things. Very practically, I'm aware of time. Very practically, none of this. Very practically, I do just want to note though that we are in an environment of FUPS data. So we are constantly butting up against this idea that of this reality that the data that we can access is flawed, it's uncertain, it's approximate, sparse, and sometimes it's just not available. So we're trying to develop methods in this space that allows us to do that. Of course, we are experts in linked data. We do lots of linked data stuff. This is going to work. So we do lots of data visualization where we look at patient pathways and how people flow through the system. We try to capture out of the back of that, what are the costs, what are the outcomes, of course. But in reality, taking a step back, we try to think about qualitatively, let's just make explicit some of our thoughts, our theory about how we think change is going to happen. So we do a lot of logic modeling around our expected effects, and then feed that into decision analytic models. So these are ones that, you still seeing the right screen? I think so. So similar sort of thing, looking at how patients flow through the system, what are the kind of consequences and costs that are accumulated along the way. Reduced in a simpler version, it's this kind of thing. We're talking about decisions around whether or not patients are admitted or not, and then what the outcomes are from that. Because of our FUPS data, we have to ask lots of questions about intervention effects, about whether people are admitted or not, and about what the lengths of stay might be in a new scenario or an existing care scenario. We do that through methods like this. I'm not going to get into it, but I'll link you some other videos. But of course, when you're asking people what their expectations are, if you ask 23 people, you get 23 different responses. We pull that together, but we also analyze it to think about, what is the level of disagreement and uncertainty within and amongst different stakeholders with their expectations. I'm going to stop this to say that ultimately, what we work towards is trying to think iteratively, because there's no point us doing some of this analysis and then walking away. It gets forgotten about because there's such turnover in the system. The organizational knowledge and understanding of this stuff goes with the person when they leave onto their next job. So we're trying to set up, how do you have a living model? How do you have living processes that engage people to revisit their logic models, revisit their expectations, and then have analyses that can update that with data as and when it becomes available. But there are some big challenges when we talk about services. So relative to drugs, relative to devices, the effects are diffuse. Lots of them are behavioral. So, we're trying to quantify some very intangible things sometimes. Of course, there are wider system impacts. You make a change in the emergency department, it has an impact in the inpatient setting and vice versa. A big thing though is that we are trying to talk about variability and uncertainty in terms of different patient groups, but also in terms of our understanding of what the evidence might be saying. So in trying to translate evidence from external settings, from research done in other states and overseas, there's uncertainty in how that may actually work in a local fast-paced, dynamic context. So I'll just leave you with this now, 119, is that, you know, my experience and where we come at some of this is that, you know, our health system, it's really hard to redesign a healthcare system that was never designed in the first place, right? And a lot of the arrangements that we have in our system don't have shared sort of motivations, desires, goals. It is a very competitive environment. It's not set up, though, to be a self-organizing competitive environment. A lot of it is overlapping. It's a very, very tricky place. We are, though, trying to manage some of this uncertainty, some of the disagreement by feeding some economic evidence into our service planning decisions so that we avoid chaos. High uncertainty, high disagreement equals chaos. If we can help people understand what their options are and understand what comes of those options when we seek to change care, then I think we avoid the chaos. And that's the kind of thing then that me and the guys I work with are trying to do off the back of my NHS and public sector experience within the hospitals and healthcare systems in Australia. Thanks.
Thanks so much, Andrew. That was really interesting too. It's incredible to see just how much goes into looking at the healthcare system and all the different ways you can evaluate it. Just wanted to see if anyone in the room had any questions for Martin and Andrew. Please unmute yourself or pop them into the chat. I think it was really fascinating to learn about both how each of your experiences have led to where you are now. Like I said earlier, Martin, I was really impressed with, well, not impressed. I took two quotes that you said. One was simple is more effective than complex, and Andrew, you took that again. And I think it's really important to remember that when we try to communicate that to people in other areas of the system. Andrew, you mentioned you're trying to keep this as a living thing, because you mentioned if someone leaves, then that knowledge, that expertise leaves as well, and these are quite complex concepts. So important to kind of embed these into the work that we do every day in the health system. All right, well, there's no questions. I don't have any questions for either of you. I don't think my colleague who's sitting here with me has any questions either. I just really want to thank you both for your time. This was really interesting and fascinating. I'll just share my screen for announcing next week's topics. Next week, we'll be looking at different economic evaluations that have been done in the aged care area. And it'll be at the same time, 12 to 1. And then the last webinar that we have is going to be looking at research impact and health economics. Oh, there's a comment here.
Lots to digest.
Yeah, lots to digest. Yeah, John, hi, John. And yes, so we have 2 webinars left. And like I said earlier, we have daily, we share daily resources on our social media platforms. So just stay tuned to our channels to see what else we share over the course of the month. And all the webinars have been recorded and will be available on the HTSA website. And also the slides, well, the webinars will be recorded. If people want the slides, I can maybe link them on the website as well, if presenters are comfortable with that as well. So on that note, I will close today's session. And yeah, I thank the speakers again for their really insightful and really inspiring talks today. So thank you, Andrew, and thank you, Martin.